Hello, everyone. This is Tony Trahan.
Hello, everyone. This is Tony Trahan.
Okay. Gotta mute that. But there we go. Okay. All right. Sorry about that. Let's take two. This is Tony Trahan with the Office of Mental Health, and we're here today to talk about understanding the OMH system, the jargon, the structure, and the concepts. I get to present today. Usually I'm the facilitator, so I'm excited about that. I'll give you a little brief introduction, and then we'll get started. So my name is Tony Trahan, and I have been here at the Office of Mental Health for about 7 years. Prior to that, I've been in different types of programs and doing this kind of work for nearly 25 years, 26 years, somewhere around there. And I do identify as an advocate, and I identify as a survivor of not only the mental health system, but I also identify as a survivor of mental illness itself. So part of my reason for doing this topic is that, myself and many of the other people that I speak with, is the first thing that they usually say is when they first experience an episode, it's just that the common phrase is, I didn't understand what was happening to me. And I think most of us can relate to that. And when we go in for services and for help, or if our families go in for help to help us, it is what you see on the screen. We're very confused. It's very difficult to figure it out. We have been and self-identified as a system that we are very fragmented. It is, and that was in, I think, the 1999 Surgeon General's report. One of the first things that they talked about, how the mental health system is so fragmented. So hopefully I'll be able to share with you some of my own learning curve to help speed up the process for people who are either not very familiar with the system, or even if you are familiar with the system, maybe I'll be able to share some stuff with you today that you didn't know about before. Even as I was putting this together, there were some things that I found that I wasn't quite aware of. So I'm not going to make my screen large for the slideshow. If it's a problem, just let us know through the chat. I got Tom O'Clair with me today. He's monitoring the chat for me, so he'll be taking care of that. And then at the end, probably about 1:45, we'll do questions. The reason I'm not going to make my screen full there is that I'm going to be kind of bouncing back and forth between the PowerPoint and the web browser. So, but if it becomes a problem, just let me know. I thought that would be most efficient. All right. So there we go. So we often talk about the no wrong door policy, which should be, which looks very good on paper. It looks good in theory, but in practice, it is very difficult to find, to just call up any place and then to get the right answer. You really need to know which door to go through, which place to go to, and you need to, in some ways, if you're a Harry Potter kind of way, you also need to sort of know the magic words to say in order to get whatever it is that you're looking for, or whatever message and information you're trying to get or give to the right people in a way that they can hear it. So what I'm hoping today is that we'll be able to teach you where to go to get your information, because although we do strive for the no wrong door policy, in reality it's not likely that that's going to happen. We do try to do that, and many of us do try to get much more general information and try to refer people and get an answer for you. But it's a big system, and I can't account for everybody. I can only account for myself and the things that we do here at the office. So hopefully we'll be able to help folks out with that. If the sound is fluctuating, then and you're on the computer, then I would suggest that you call into the teleconference, and then you would be able to hear a little bit better. I'll also try to speak a little more loudly. So the first thing I just want to do is I want to put out a disclaimer. This is one of my favorite quotes: never ascribe to malice that which is adequately explained by incompetence. So this is a huge topic, and invariably it's an incomplete topic, and it has to be, because there's just so much stuff out there. The map is not the territory, so we had to leave some things out. There were a couple things that I did leave out, but generally speaking, if I did leave something or someone out, and there's an organization out there that's on the phone that felt they should have been included, it was not malice. It was unintentional and incompetence. So please send me a note afterwards, and I will do what I can to rectify it in the archived version of this to make sure that that information is also included. So I've got two agendas today. So the first agenda is my agenda, and the second one is yours. So here's mine. I want to talk about from the global to the local. So we're going to start off with national and federal programs. Then we'll do multi-state, multi-agency statewide programs and initiatives. We'll do state-operated, which are licensed and unlicensed. And then we'll do community-operated, which are also licensed and unlicensed. And then we'll talk about what's the difference between licensed and unlicensed as well. Part two is your agenda. And what happened was when I asked for folks to send me in what they would like us to talk about today in the pre-registration questions, this is what I got. I got a lot of stuff that I hadn't actually planned on covering, but I want to make sure I address your topics and the things that you said you were interested in. So I sort of grouped them together. So we got regulations, we got families, grievances, moving to independence, and why is that so hard? Medication for low-income individuals, substance abuse, children's services and medication recovery, health homes, housing, rural services, acronyms, geriatrics, hospital closings, cultural issues, and peers, the career ladder training and certification. So that's all. That's all we're going to do. So we'll start off here, as I said, with the national and federal programs. This is sort of like the mother of all programs federally for our population. It's the Substance Abuse and Mental Health Services Administration. You'll hear it referred to as SAMHSA or SAMHSA. Sometimes they'll invert the H and the S. So this is really a lot of new data will come out of here, new laws, new policies. There's a lot of information that it gets shared, and I do understand that there is a little bit of a lag when it comes to using the browser, so I'll try not to do it too much because I don't want people to get dizzy. But there is a mailing list, if you see there on your lower right. You can join up there and you can get the news alerts as they come out. So this is one of the major organizations that are out there. Another one of the major federal organizations is the Centers for Medicare and Medicaid Services, also known as CMS. Oftentimes there will be letters sent from CMS to the state Medicaid directors giving them information about particular things. One that I remember that just because I was working on it happened in August, I think, of 2007, that was sent to the state Medicaid directors just telling them to include peers in their services and how they can do that and how they can bill Medicaid. So this is has a lot to do with billing. And numbers and money and that kind of stuff, which is not my area of expertise. But just so you know, when people refer to CMS, that's usually what it has to do with. It has to do with proving medical necessity and billing Medicaid. But you can, and I probably should have said this, we're doing mostly a treetop view today to get a wide breadth of stuff, which means we're going to sacrifice depth. So we're not going to get too deeply into any one particular thing. The next one here is this is referred to as NASHBID, National Association of State Mental Health Program Directors, and what they do is they do a lot of good technical assistance. Joe Parks, I believe, is still the head person there, and actually I think he's going to be doing grand rounds for us here at OMH. And one of the things that they did fairly recently that has really helped to shape the state's mental health policy here, or one aspect of it, is the morbidity and mortality report. And what that did was that showed us that people with a mental health problem or people with a mental illness, they die 20 to 25 years sooner than the general population. And I mean, generally we thought that people with a mental health issue generally tended to die sooner, but we didn't realize it was that much. So there's been and SAMHSA took the lead in this around 10 by 10, so they want to reduce that by 10 years in 10 years. So they want to reduce the amount of time, or they want to increase the amount of time that people are living, the average amount of time that people are living. So they put in some information about how behavioral health and physical health are intertwined. We started paying a lot more attention to things like smoking, and these are all preventable things that can help us live longer. So screenings, just the standard screenings that regular people get, getting a baseline mammogram so that way you can compare it later on. These are all things that will help us live longer. And we also have a responsibility too to quit smoking, to exercise, and to eat healthier. So that was a major technical report that came out. It gave advice to the states as well as others, and part of our system has been changed by that, and we have paid a lot more attention to physical health. And the next one here is the National Mental Health Consumer Self-Help Clearinghouse. Basically, it is what it says. There's a lot of good information here. You can see on the left-hand side, there's training and technical assistance. If you scroll down, and again, they also have a newsletter that you can subscribe to, and you can go down, and they've got a search engine here, and you can go down here through a number of topics. So this is a great place to get a lot of information that focuses more on peer support and self-help, and it comes more from that angle rather than from the federal sort of angle. So it's just a different perspective, but the same types of things. I think that was the main four. All right. So here are some more multi-agency statewide programs. And we'll go to the next one here. So this is NICE, is the way we pronounce it. It's the New York Employment Services System. This is actually led by the Office of Mental Health. It's a multi-state agency initiative. So you can see the Department of Labor, the Education Department, Blind and Visually Handicapped, OASIS, which is the Office of Alcoholism and Substance Abuse, people with developmental disabilities, and the Office of the Aging. And we've been working with veterans as well, and recently we've been working with HIV providers. This is it's a new system. I won't get too much into it, but it's a fairly new system that's been around for about a year, which is still fairly new. Basically, it turned New York State into an employment network. It's the first one of this size in the United States. What that means is that for people who join this administrative employment network, they don't have to do all the paperwork required to be an employment network, but they will get the benefits of helping people who have a ticket to work get back to work. So when people who have a ticket to work do get a job or provided services, there's actually milestone payments from the federal government. So in essence, people are going to be getting paid for doing what they were doing before with very little extra work. You do have to document the services that you do, but there's money available that wasn't there before. And our initial estimate was, without having to do anything else, that there was about 25 million, 24.9 million that was left on the table that we were eligible for, but because we weren't an employment network at that time, we weren't able to get it. So the money is actually coming in, the checks are coming in, and it's real. And this is a great system for everybody, in my opinion. But I'm biased about that. Next thing is the Justice Center. So this is also fairly recent, and this is, I believe, due to be up and operational on June 30th. They just hired a director for it. His name is Jeffrey Wise, and from what I've read about him, and I remember I remember seeing his name here and there. And I probably have met him somewhere along the line, but everyone that I've talked to has said that he's a fantastic person and an excellent choice for the job. So I'm looking forward to that, and hopefully I'll be able to meet him at some point. But basically, the Justice Center is designed to it's got a little more teeth to it than some of the previous things that we had in place. So it's a checks and balance. It's an opportunity for people to bring their complaints. So people with special needs is what they say in here. So that's the OPWDD population, developmental disabilities. and OMH, people who are also in our forensic hospitals. So basically people who are being served are able to put in, if they have a complaint, they can go to the Justice Center. And the Justice Center has some different types of investigatory powers. So, you know, keep your eye on this page. It is in development. Next thing is the SAFE Act. So this is very recent. This just went into effect on March 16th. You know, this came out. It's in regards to the gun control. It's a very emotional issue. I'm not going to talk too much about it because it's very new and I really don't know that much. But here's the page. This has the information on it. There's a video here. There's a PDF here. There are some frequently asked questions that you can take a look at, and that's about all I have for that right now.
There is the ability to ask a question if it's not in the FAQ at the bottom of the page.
Yes. So, and that's pretty much true for every OMH page. At the bottom of the page, there's usually a place where you can send a message to get more information. So, you know, it's got a little captcha thing there, so we know you're a human being. All right. So the next thing is, this is the SAGE Commission, and that stands for Spending and Government Efficiency. They just came out with their final report, basically, and I'll just read here. So the SAGE Commission's charge is simple. It's to make our state government more modern, accountable, and efficient. So they did, you know, their reviews and their investigations and their data collection and their forums, and they have put together a final report which came out in February, so just last month, and you can actually take a look at it here. So if you click on the final report, actually it's very big, so it may not download quickly, but you can take a look at it here, and there are some things in here about OMH, and this will help address what people were asking about earlier. So I'm going to read this. So over the next 2 years, OMH plans to create regional centers of excellence for the diagnosis and treatment of complex behavioral health illnesses. This effort will ensure that there will be ample capacity for treating individuals with mental illness who require inpatient services, and the savings related to this state psychiatric center regionalization initiative will be reinvested to support the same or greater level of community-based services. This reinvestment will help facilitate earlier and better access to care. So there's some more information, obviously, in the SAGE Commission report. I suggest you take a look at it. I drew this from page 16. There's some more stuff. It starts on page 15. And I believe actually on the OMH webpage, Kristen Woodlock, she's our acting commissioner right now, and she's going to be doing a series of listening forums on this very subject of behavioral health, regional centers of excellence. So obviously the SAGE Commission is another avenue that helps influence OMH policy. So here are some statewide grassroots advocacy programs. So mostly what I've been talking about previously had to do with government programs or state or federal programs. So that was mostly government. The National Self-Help Clearinghouse was not. So these are some other ones that are not, as far as I know off the top of my head here, they are not government agencies. So the first one here is NIAPRS. So I know here we are not supposed to be talking in acronyms, but I can't help it. So NIAPRS stands for the New York Association of Psychiatric Rehabilitation Services. They're a chapter of what I believe USPRA is the sort of national mother agency. This is their website. They do a lot of good training. They do a lot of stuff to help influence public policy. They're very proactive in promoting peers. Harvey Rosenthal is the director, and he was actually here last month talking about the health homes. So they do a lot of education, a lot of regional forums, a lot of things like that. They've been around for a long time. They have both peers and professionals on their staff and board. Next one is the Empowerment Center. This is a peer-run organization. They have, as you can see, a whole lot of information on their just on their front page. So I suggest you take a look there. They've got some really good stuff that they do. They focus, as my understanding, they probably do a lot of other things that I'm not aware of, but one of the things that I know that we've worked with them on is helping build boards and helping teaching people how to create good sound boards, good sound programs, good sound agencies. So they focus a lot with the peer-run folks. They provide a lot of technical assistance to providers as well, and they've been a huge asset to us. The next one we have here for families is Families Together in New York State. I have to be honest, I don't work a lot with the children's division in the areas that we do. Certainly, it's always been a pleasurable experience. Tom, do you have any? Tom McClure certainly works with a lot of families, so I'm going to ask him if he has anything that he wants to say about.
Yeah, we have worked in partnership with the Families and Children's Division here at OMH, who works with and oversees, has contracts with Families Together in New York State. Families Together in New York State is a family organization that is a state affiliate of the Federation for Children's Mental Health Services. Wonderful organization. They are very well versed in childhood behavioral disorders and mental illnesses, developmental disorders, and so forth. They one of the better versed organizations in the state when it comes to children and their needs. We have, in our capacity, engaged them in the Transition Age Youth ad hoc committee that we are doing internally here. So we look forward to working with them further in the future.
Excellent. Thank you. So we moved on to the next page here. So another family organization is NAMI, and that stands for the National Alliance on Mental Illness. They are an affiliate of the national NAMI, and so this is the New York State page, but there are also local affiliates in each area, and you can take a look there and you can do a search to find them. They're more of a family-oriented program. Obviously there's peers, and when I say peers, I mean people who are recipients of services or have received services. Excuse me, I don't mean to be confusing, because peer can be used in a lot of different ways. So that's how I was using it there. They do a lot of training. They're involved in forensics. I believe they just started getting a little more heavily involved in the forensics, and they've been very helpful. Because we are all in this together, and certainly family, when we engage the families as part of the treatment, that can be very helpful. But if we don't engage families in the right way, or families don't know how to access services and how to get in the system, it can be very, very frustrating. So, and that's another reason why I'm doing a webinar like this, is to help people not get frustrated and to help move it. Tom?
And also with NAMI, they support families who had no prior knowledge or experience with a loved one who suffers from a diagnosis. So there are family members without diagnoses involved, as well as individuals with diagnoses involved. And some of the trainings they give are national best practice trainings, such as the family to family. So they've been there, they've done that, and they can help others through it.
Thanks, Tom. The next agency here, grassroots statewide agency, is MHEP. It stands for Mental Health Empowerment Project. They are a peer-run agency, and they, again, like the Empowerment Center, they do a lot of training. They do provide a lot of technical assistance. They're very active in the communities. Again, they're statewide. They teach RAP. We've worked with them to help bring RAP, which is Wellness Recovery Action Plans. Sorry, we'll talk about that a little later. To bring things like that into our hospitals and into our forensic hospitals. So they're a great partner with us, and we certainly enjoy working with them. And this is their website. And Mental Health Association. This is in New York State. So sometimes what we do is refer to this the Mahaney's, as you can see, which is a little funny to say. Sounds a little funny, Mahaney's. So this is another organization. There's a National Mental Health Association that's out there that has to do with America. Now known as Mental Health America. Okay, and that was the bell, as I recall.
Mhm.
So there was a bell as their symbol that was created from the chains and shackles that were melted down from a state hospital. So there's a much longer history than that. I'm not doing it justice, but I did want to let people know that they're out there, and they also do, just like NIAPers and the HAP, they also do lobbying, and they do a lot of work around legislative stuff to help inform not only the public, but also to work with the legislators so they can give them another perspective.
And they've got a very good referral service for anybody who's looking for services in their area and not quite sure where to turn. Turn to your local MHA as one resource.
Thanks. All right, so let me go back here. So now here are some statewide training agencies that are out there. We have the Center for Practice Innovations, and they did a webinar for us a couple months ago, and that's up on YouTube if people want to take a look at that. They describe some of the things that they do. They do work. Their trainings are designed for the entire country. They do a lot of stuff on the evidence-based practices of supported employment and the ACT, assertive community treatment, and as well as focused integrated treatment, and we'll talk a little bit about that. But they do some great trainings, and we're actually working with them right now on providing guidance with them around peer specialists on ACT teams. But it's going to be transferable to peer specialists in general, so that's a lot of fun. The next organization here, let me actually pull up their. So that's Center for Practice Innovations. That's their website, and they do things like wellness self-management. You can go in there and you can actually, when it says purchase products, there's some things that are in there for free, like the wellness self-management workbooks are in there for free, and you can download them. You do have to create an account, but that's pretty easy to do. And it's a good resource for. It's mainly targeted for providers, but anyone can access the information that's in there. This is the Family Institute for Education, Practice, and Research. They're out west in Buffalo, and I'm looking forward to working with them next month. They'll be doing a webinar on their program, and they're going to be telling us an awful lot about what they do around education and training and providing support to families and all the stuff that they do. So I don't want to let the cat out of the bag too much, but they'll be working next month and giving us a webinar, so they'll get much more into depth with that. And this one is fairly recent. This is the Academy of Peer Services. There's a lot of modules, online modules in here for peers, people who are recipients of services, people who are peer specialists, whether they're working in the field or not working in the field. They have access to a number of training modules that are in here to help raise the level of competence and raise the level of information that's out there for peer specialists to bring to the team. And that's the end of my first set of browser stuff. Next thing I want to talk about is just a brief review of political science. There's three branches of government: executive, that executes the laws; judicial, that judges the laws; legislative, makes the laws. And that OMH is part of the executive branch of government. So we execute the laws. We don't decide whether they're good or bad, and we don't make them. In fact, we cannot lobby or do anything like that. We can teach people how to lobby, and we can teach people how to advocate, and that's good. But we don't get directly involved in any of that kind of stuff. Here's the page for the Office of Mental Health about OMH. It's got a number of interesting links on it. I'm going to show you some of these in a little bit, but I just wanted to give you that sort of the main page of the About OMH. And where are we going? This is a flow chart or an organizational chart of where we're at right now. So for people who are viewing this sometime in the future and it's archived, some of this may change. It's got the very specific people who are in their specific jobs, so some of that may change over time, but that's how it is as of right now on March 20th, 2013. So you can see that it's sort of color-coded. It's sort of blue and pink, so you can see that those are sort of like the two major kind of divisions. and that we've got the main person is up at the top, and that's, as I said, Kristen Woodlock. She's the commissioner. She's the acting commissioner for right now. And then you can see the different subdivisions that are underneath there. And actually, I'm going to make this page large so people can see it. So you can see this a little bit better. So you can see the different divisions that are here. And then if you go down to about the middle of the page where it says Office of the Executive Deputy Commissioner, you can see that all of the things that fall directly under the Office of the Executive Deputy Commissioner. So there's field offices in the 5 different regions. We've got investigations, we've got audit, and then down at the bottom you can see the Division of Adult, the Division of Adult Services, which handles all of the adult things in the state. The Division of Children and Family, Division of Forensics, Office of Planning, Medical Informatics Officer, Psyches, Center for Human Resources Management. That's with employees and whatnot. So you can kind of see where everything falls in here, and that's just sort of a treetop view of how OMH is organized. As I said, there's 5 different regions and 5 different field offices. We have 24 different facilities. So we've got the Western, Central, Hudson River, New York, and Long Island regions. Let me pull that up for you. So, and all of this stuff, you know, I left all of the links in the presentation. So I did send this out earlier as a PDF, and I'll send it out again because I did make a few changes between then and now. So you'll get those, and you'll be able to follow up on these on your own. I thought it was better to just go directly to the pages than to show you how to get there from the home page. But these are where the field offices are in Syracuse and Poughkeepsie, West Brentwood, Long Island, 5th Avenue, New York, near the Empire State Building, and in Buffalo. And then you can see here where the 5 different regions are. We've got the Western, Central region, Hudson River region, New York City, and Long Island. This is a directory of our facilities. So we have the 24 facilities, and you can see where all of these are. If you click on it, it'll open up a page, and because I've got so many things open, it may not come quickly. Here we go. So this is Buffalo's web page, Buffalo Psychiatric Center's web page. Gives you a whole lot of information here that's specific to the Buffalo Psychiatric Center and the things that they do. So you can see they have outpatient, inpatient, residential services, vocational. They have a self-discovery center, which is really a wonderful thing, and Elmwood Wellness Center, which I'm going to assume is probably a clinic. So you can see the different types of things. Actually, I probably shouldn't assume that because that's probably outpatient services, so I'm not sure what that is then off the top of my head. And I'm not going to click on it now to find out. So that just gives you an idea of what's happening locally. So you can click on for one of the state hospitals. You can see what's happening specifically in your area. And this is a picture of the adult psychiatric centers. So I said there were 24 psychiatric centers, and there's not 24 on the page here. This just shows you where the adult ones are. So it doesn't include the children's ones, and it doesn't include the forensic ones. So these are the adult ones. And just to make note that Hudson River PC, that was, and PC stands for Psychiatric Center, that was consolidated in with Rockland PC. So that's where we stand right now. And just as an FYI, you know, as they talk about trying to consolidate things from the SAGE Commission, what is put in there, there's nothing specific. There's just sort of a general thing in there about that. New York State does have more hospitals than the next nearest 2 states, which is Texas and California, who both, you know, sort of mirror our population fairly well. We have more than twice as many as the next nearest one. So.
And we have the most hospital beds per capita than any other nation in the world.
So there are a lot of beds here. So look, I'm putting down here local community involvement, and maybe this isn't the right header for it, but basically where my head was at when I put this together was, you know, for people who are out there in the community who want a little more information locally or want to get involved locally and be helpful, that's kind of where my head was at when I organized it in this way. So I apologize if that wasn't the right place to put it. So the Conference of Local Mental Hygiene Directors, which we affectionately call the clam head here, because everything needs to be quick when you do that kind of stuff. So you've got the Conference of Local Mental Hygiene Directors, Community Services Board, Mental Health Planning Advisory Committee, and the Mental Health Services Council. And these are all places or agencies that you can go to, or committees or councils that you can go to help get your voice in at the local level. In some cases, it's statewide level too. Let me go here. So I'll show you their webpage. So this is the Conference of Local Mental Hygiene Directors. This is their webpage, and you can scroll down. You can find where your county director is. It's got a search engine in here, so you can take a look at the different things that they have available for you there. And for people who are looking on health homes, there's some stuff on health homes. And this is also part of their page, but I wanted to bring this up. So this has to do with the Community Service Board. So this is the mental hygiene law that provides for that. The local government unit, as you can see here, will have a community services board for services to individuals with mental illness, developmental disabilities, and those suffering from alcoholism and substance abuse. They do have separate subcommittees for those. Sometimes they do combine them a little bit, which is, I believe that's okay to do under the law. But it is important for people who are recipients of services, for people who have individuals with mental illness, or people who have mental health problems and want to help get their input into the system for them and families. It's important to have that lived experience perspective involved in the planning process. This is the Mental Health Services Council, and you can come here and take a look. You'll see, I'm not going to go into great detail, but you can come here and you can see and go through all the information that's here on the Mental Health Services Council. In fact, they just had a meeting, I think earlier this week. So there are members there. So if you want to get more information about that, there should be a thing at the bottom here. Yes. So you can send any information to the Office of Planning. You can do the same thing when it comes to the Mental Health Planning Advisory Committee. You can also send any questions that you may have about that. Mental Health Planning Advisory Committee is similar. I believe that they are, don't quote me on this, but I believe that they are involved with how to use the block grants that we get from the government, from the federal government, and how best to use those. So we have a mix of providers and advocates as well who join us for that. I think you should be able to get some information on that if you touch base with the Director of Community Services through the clam head. All right, what's the next topic here? Next topic, I want to talk about the Division of Forensic Services. We have 4 forensic hospitals. Forensic, what does that mean? What that means is somebody has committed a crime. And we don't have NGRI here in New York State. NGRI stands for not guilty by reason of insanity. That we don't have that in New York State. What we have, and I believe I'm quoting the law verbatim, is not responsible due to mental disease or defect. So the person is guilty but not responsible due to mental disease or defect, and that's the language that is used. If that's the case, and this, these can range from arson, burglary, murder, that kind of thing. So people are moved into through the criminal justice system, are held in forensic hospitals. Forensic hospitals are secure facilities, so they have much more security there. They have much more a heightened sense of awareness for safety, which is all helpful. It's different than a prison. So in a prison, there's general population. There's just everyone's kind of mixed together. If you do have mental health issues, there are things that are available for people to get treatment there. If you read the papers, it is more or less successful. We do run a place for people who are not able to get appropriate treatment, or they need extra help, they can go to our Central New York Psychiatric Center, which is near Utica, and that's where people would go to get some, to get stabilized and to get a little more on track, and then they go back to prison and they serve their time. The major difference between those two things is if you're in prison, there's a specific set time that you are going to be in prison for, and then you are released. In a forensic hospital, there is no specific set time, and you can be in there for the rest of your life, actually. One of the places that a local community program is called the Urban Justice Center, and we've worked with them a little bit. Actually, that's the Central New York PC has worked with them on a couple of different projects. Excuse me. They're down in New York City. Excuse me. And this is their webpage, so you can see they've got the mental health stuff here, but they do a lot of stuff with criminal justice. So if you're in New York City, or even if not, you can still give them a call, and they might be able to be helpful if you have a forensic issue. Here's a program that is not very well known at all. This is the federal bonding program. So when it comes to re-entry into the community for people coming out of prison, it can be very difficult. The recidivism rate is very high. I just think it's very important that we try to do everything that we can from our end to help people merge back into society and help them back with getting their lives back and staying out of trouble. One of the best ways to do that is with a job, but it is difficult to get a job if you are a felon. So one of the things that is available out there is the federal bonding program, which in a nutshell is essentially an insurance program for employers that incentivizes them to hire people who are convicted felons. What it is if something happens on the job, if the person does damage or steals or does something like that, then the employer will get reimbursed through the federal government. So they don't have anything to lose in that regard. So it is an incentive program to help people get back to work. And here's a webpage so you can get some more information about that. Not a lot of people know about this, and really, whenever somebody says that they're looking for work, we should just drop everything and start helping them to try and get a job, because that's when they're most motivated, and working is one of the best things you can do for your mental health. And then this is the home page for the Division of Forensic Services, and you can see that there's some different web links here, and there's some different information, so you can see what if you want to educate yourself. Forensics is a very interesting topic. It's a very interesting place to work. I really enjoy it, what I get to do there a lot. So here's what I was talking about earlier: not responsible for criminal conduct due to mental disease or defect. I almost got it complete. I almost had it quoted correctly.
Close.
I got the main gist of it. Okay. So I went through all of those. This is a very, very important thing that we have done here, and I'm very grateful that I was able to work on a lot of this. This has to do with the taxonomy. So the taxonomy is how we organize our programs by different program types. So this is where I think people can start to really sort of where the rubber meets the road, and people may be able to relate to this the most. So I'm going to talk first about licensed programs. So licensed programs, these can be run either by the state of New York, or they can be run by nonprofit organizations like a Catholic Charities or a federation of organizations, or something like that. So these all need to have a license. They must have an operating certificate to operate these programs. You can't call yourself an ACT team unless you have a certificate for that and have been licensed. So you can see, so it's ACT teams, it's CPEPs, outpatient, like clinics, continuing day treatment, partial hospitalization, IPRTs, and PROs. Psychiatric inpatient units, hospitals for mentally ill, freestanding. This is all quoted that I did. I just cut and pasted, so it's their language, not mine. Residential treatment facility for children and youth, and that's another acronym that you may see is RTF. That stands for Residential Treatment Facility. Residential housing facilities such as community residences or apartment treatment programs, but not supported housing. And I want to take you to this page. So this page is the Find a Program page, and you can actually get to it right from, this is the OMH main page. So right there with Find a Program, this is one of my favorite pages, and I use this a lot. So you can look up any program that OMH not only licenses, but also funds. So these are both licensed and unlicensed programs, and this is where I would start if I wanted to learn more about the programs that OMH either licenses or funds. And as you can see, you've got all of the counties there. I would suggest that people go to an advanced search, and in here you can actually get much more specific about what you're looking for. So you can see there's program category, subcategory, and program type. So the program category would be, let's see if we can take a look here. So residential would be a program category, a support program would be a subcategory, and then a program type would be like this, apartment support, congregate care support, or an SRO, that's a single room occupancy. So that's how it's sort of broken down. And when we talk about program types, that's what we're talking about. We're talking about these things that are in white or that aren't highlighted in the green or blue. So those are the different program types that we have. You can look for special populations, eating disorders, geriatric, etc. And you can look here for whether it's recipient run or not. Now, we use the term recipient run or peer run interchangeably. We also use recipient run and peer run interchangeably with family run. So for the family support programs that are family run, they also, let me just scroll down so you can see that whole thing. They also meet this criteria of 51%, and a preponderance of staff are either family or peer. And if you want to do that, you can click yes. And then if you click go, you will get that there were 171 programs that are peer run. And then you can see they've broken it down by the different categories here. So we have a PROS, which is personalized recovery-oriented services, as we were talking about before, so the residential, unlicensed housing, etc. So one of the things that I'd like to show here, and I don't mean to pick on any particular area, but so when a program is, when licensing comes out to certify a program, they give them a certificate for X amount of months. It's usually 12 out of 36, 24 out of 36, or 36 out of 36, based on whatever sort of whatever they find there, and whether or not they need to improve, or they are not doing so well, or they're doing great, so they give them a 36-month. But if not, then they'd give them a 12-month, and then they would come back and visit. And you can take a look at that stuff here. If you look at program details, it should say, all right, that's not there. Let's see, maybe it's here. All right. Well, I looked at this before, and the certificate, there it is, license duration. So this one is 9 of 36, so they're going to come back and take a look for that. All right, so that's just to give you an idea of where a place is at. Now, one of the things I did recommend to them is because they do a let's see, the Bureau of Inspection certification. They do unannounced inspections of programs. But what they do is they do a debriefing afterwards, and one thing I did encourage them to do, and if you do have a loved one in one of these programs, in like a housing program or whatnot, is to invite the families in so they can talk about some of the things that they found, some of the things that they're doing well, and some of the areas where they need some improvement, but to help bring the families into that process as well. I think that would be beneficial. So. We talked about find a program. We talked about what license programs are. Those can be state-run or run by a community, as I said. Same thing with these program types, such as advocacy support, family support, transportation, self-help, vocational. All of those are non-licensed programs. So they have their own sort of board of directors, their own governing bodies that they do their own quality assurance with. Let me just go back up here. So if you're looking for what a particular program does, you can press on up here where it says program category and program types, and you can just click on, you know, whatever one you're looking for, and then it'll bring up the definition. So this is the definition of a crisis residence. This is what they are being paid to do. And it goes through all of these. I don't want to go too far down, but you know, so you can just take a look and, you know, what program am I in? What program is my loved one in? And you can take a look, and these are the program definitions. Or if you're looking to find a program, this is what they're defined as. Okay. So hopefully that helped. That was always a big problem for me between trying to delineate between state and community. So state is state-run programs, and community are ones that are run by usually nonprofit organizations. I don't know why, but when I first got here, I had a hard time keeping those things straight. Another concept that you'll hear a lot about are evidence-based practices. So these are things that have been, you know, tested, they've been peer-reviewed, and they've been shown to, there's evidence that shows that these things are going to help someone versus doing nothing. And there are, and that sounds kind of, you know, it sounds like, well, duh, yeah. But there are things out there that really aren't effective at all. You know, there are some programs, and I'm not going to out them, but there are some initiatives and some things out there that are interventions that they really don't do anything at all. They may not do any harm, but they've not been proven to be helpful at all. And these have. So I've got the list of the main ones here. And the reason I've got Center for Practice Innovations is because they're the agency that does most of the training in this. So we've got ACT, which stands for Assertive Community Treatment. That is an evidence-based practice. ACT is considered it's a hospital without walls is what they call it. So there's a whole treatment team, a psychiatrist, a nurse, vocational, family, usually a peer. Peers aren't required, but that's a 24/7 program for people to help people stay in the community. But they don't really. These are folks who don't do well in traditional services, traditional clinic services. ACT and also intensive case management. Intensive case management is not an evidence-based practice, but those are the two things that if someone is issued an AOT order, which stands for assisted outpatient treatment, that they would be mandated to be in one of these two programs. So they would either have to have an ICM or they would have to be in an ACT team. The next one is IDDT, which stands for Integrated Dual Diagnosis Treatment, and that's for co-occurring disorders for mental health and substance abuse. But of course, you know, we have to New Yorkify it, so we changed it to FIT, which stands for Focused Integrated Treatment, and that's what we do here as an evidence-based practice for that particular subject. Next thing is supported employment, and again, what we call it is individual placement services, I believe. So that is our supported employment program. And illness management and recovery, we changed to wellness self-management, WSM, and all four of those things you can get training on those through the Center for Practice Innovations. Medication management is another evidence-based practice, and through that we have psyches, and I should have probably pulled out what that stands for, but I know that the CK stands for clinical knowledge. So basically that's a way for us to monitor polypharmacy, because there's no evidence that says more of a particular class of medication is better. So if someone is on an antipsychotic medication and it's not particularly helpful, put them on another one, another antipsychotic medication, and another antipsychotic medication does not help at all with symptom management. And actually it does harm, because those medications have side effects and they harm your body. So we want to reduce polypharmacy. That is one of the indicators that contributes to people dying sooner. So we want to make sure that we're not over-medicating people, and this is a way to monitor that, specifically or mostly with the people who receive Medicaid. And family psychoeducation, and as we talked before about NAMI and the Family Institute, that is another evidence-based practice. When families are involved, it can be very, very helpful. There's also, and you'll see the link up there, there's also a from SAMHSA. You can see this is SAMHSA's National Registry of Evidence-Based Programs and Practices. So if someone has a particular thing that they want to try, you may want to just take a look in here and just see what the efficacy of it is and see how well it's been shown to work in other populations. A couple of concepts here, and I want to start moving through this a little quickly, so I don't mean to give it short shrift, but these are some concepts, very common concepts that are out there. Medical model versus rehab recovery model. I'm going to get into that in just a minute, but that's a big shift that we've gone through as a system, and we're still working towards the rehab recovery model and moving away from the medical model. Peer support is part of that. Peer support would be a peer is someone who has experience, lived experience in the mental health system, lived experience with mental illness or mental health problems, and are able to talk to each other and provide support. Like I said in the beginning, when this first started happening, I didn't understand what was going on. Having somebody who's been through that is very, very helpful. Peer support is not just for peers. It's not a concept that's just unique to mental illness or mental health. It's also the big place that I recall was with breast cancer survivors. I read a study somewhere where people who are part of a support group in breast cancer, the mortality rate actually goes down by 40%. So there's strength in people sharing their stories and working together. So that's a huge thing. Peer support, self-help, they kind of get lumped together. They're a little different, but you get the general idea. RAP plans, Wellness Recovery Action Plans, this is a great way. It's almost like developing a map on how to be well and thinking about really getting thoughtful consideration to what am I like when I'm well? What am I not like when I'm well? What are the things that trigger me? When is it time for someone else to take over? I would suggest that you take a look at their website with Mary Ellen Copeland. I'm sorry I don't have the website here, but if you do a Google search, you can find it pretty quickly. It's a fantastic, fantastic thing to use, and we really promote it. Another thing to help people stay in control of their treatment are psychiatric advance directives. Related to that is also healthcare proxies. So psychiatric advance directives, you do it when you're well to talk about the things that you prefer. So if you prefer not to receive a particular medication, if you prefer to have a male psychiatrist or a female psychiatrist, it's a way for your preferences to be honored at a time when you may not be able to articulate what your preferences are because you're in an altered state, or you're delusional, or you're coming into the emergency room and you're psychotic and not able to process things or talk about things appropriately. And forgive me for the language that I'm using. I'm talking quickly, and I'm trying to use the language that is most common, but normally I don't refer to things in that way. Thinking of it in terms of sickness or illness. So.
And the psychiatric advance directive is as important as a healthcare proxy because you never know when crisis is going to come.
Yeah, healthcare proxy, that gives someone else the ability to make decisions on your behalf, medical decisions on your behalf. So, big concept here is Olmstead. The Olmstead decision, basically, long story short, it was a law that says that people need to live in the most integrated setting possible. This is why we try to help people move out of institutions. This is why we try to help people move out of adult homes, out of psychiatric hospitals. We are federally required to do so. So for people who are in our hospitals and are able to live with supports in the community successfully, we need to help those folks move out into the community. So that is a huge guiding principle for not just our state agency or our state, but federally. Now, this is where we're talking about the medical model versus the rehabilitation model. And I do want to talk about this. This was a seminal study. By Courtney Harding. They'll call it the Vermont longitudinal study, or they'll call it Courtney Harding study. This is a huge thing that happened that really helped shift our perspective from one of hopelessness to hopefulness. There were 269 back ward hospital patients. They lived in the back ward. They were hopeless cases, considered most severely disabled, chronically mentally ill, in the hospital. They were slow, confused, frequently had some impairment or distortion, unpredictable. They lacked initiative or were unmotivated, is another way to say that. They were poorly educated, repeated, and prolonged hospitalizations, and they had little social support. So these were, and the reason that we're saying this is because we want people to know that they didn't cherry pick, the low-hanging fruit. They really looked at the people who were considered the most hopeless in this particular study. One half to two-thirds of these folks recovered, and this is the definition of recovery. It's a very hard definition of recovery, having 4 criteria: having a social life similar to others in the wider community, holding a paying job or volunteering, being symptom-free, and being off psychiatric medications. 62% of the people diagnosed with schizophrenia met 3 out of the 4 criteria there. So we contrast that with what they were doing in Maine. So in Vermont, it was 32 years. One half to two-thirds of the consumers displayed marked improvement or recovery. And the treatment there used a rehabilitation approach. In Maine, there were poorer outcomes. They did not use a rehabilitation approach. It was more of a medical model and stabilization approach. And here you can see the compare and contrast there. So you can take a look at this. People are expected to live in real housing. No, in the Maine, they're expected to be in congregate care. People are expected to work in Vermont. People are expected to be on benefits for the rest of their lives. It's called the Pygmalion effect. People tend to live up to the expectations or live down to the expectations that are set for them. So it's really important for us, for people who are providers, to hold hope at the forefront. Hope is the gas that drives the car of recovery. In order, just to get a little scientific, things have to be reliable and valid, so they need to be repeated in order to sustain some legitimacy. So as you can see, here are some more longitudinal studies, and the significantly recovered, with the exception of the fourth one down in 1979, they're all 50% or higher. These were in America. They did them throughout the world. Here's another 4 studies, and again, over 50%. That is a huge shift, though, people. You need to understand that, no longer are we saying that, a diagnosis is now a death sentence and we expect you to get worse. Now it's, okay, you've got this thing, you need to adapt. It's not about getting rid of all your symptoms. It's about adapting to your symptoms so you can live in the community and live in the world. And the problem is that the difference between research and people who are in the field doing direct services is that the people who are doing direct services don't see the whole population, and the researchers do. So the people who would provide direct services usually see us when we're at our worst. And they don't see the people when they're well, because there's no vested interest for us to come back and say, hey, I was sick and now I'm better. That usually doesn't happen. We've been trying to promote that some here, but I'm not going to go into that right now. So these are your stated interests. Talked about regulations and families. Families we already talked about. So for regulations, you can go here. These are the laws of New York State. They've got all different ones here. And if you scroll down, you can see mental hygiene is there. And if you click on that, it gives you the laws of New York State in regards to mental hygiene. This is the Office of Mental Health. These are regulations that are put up here. And these are up for public discussion. So these are put up here for the public. These are proposed rules, and they're going through the public review process at the moment. And again, here's guidance documents for adult services, behavioral health organizations. So these are guidance documents, not strictly regulations, but in the same area. Okay. As I said, we talked about families, so I'm going to go through these a little quicker. Medication for low-income individuals. This is something that not a lot of people are aware of, but on the NAMI national website, there are a list of the different pharmaceutical companies, the medications that they provide, and you can call them and see if you're eligible. If somebody needs medications but is not on Medicaid or Medicare and doesn't have a way to pay for them, this may be a way to be helpful. And sometimes there's a transition period where people are in that sort of donut hole area and they really need some help with this while they're waiting for their benefits to come in. So another thing too is when people are released from prison, there are some waiver programs that Social Security can provide, so you can get expedited Medicaid. And substance abuse co-occurring disorders, I already talked about the FIT program, which stands for Focused Integrated Treatment. And this is a letter from both the Office of Mental Health and Substance Abuse Services. Basically, talks about that in here, so you can take a look at the training program that was put together when we were working together at that time. And that's, I think that's how the FIT initiative came out. Grievances. So with grievances, there were quite a few people who asked questions about that. Each community program has to have its own, has to have a grievance procedure, and it has to be given to people, and it has to be displayed prominently. So each program needs to have that. Now, one of the problems that I found was that when people first come into a program, there's a lot of information being given, and the grievance procedure is one of the things, and it usually, a lot of that stuff doesn't stick. So it is important, I think, to review it from time to time with the people in your program to make sure that they understand. The mantra that you'll always hear is that it's best for these things to get dealt with informally at the lowest level possible. It's best that we do that there, because it can create lots of problems when you try to get someone else to beat somebody else up for you. It just does not work very well. It creates a lot of resentment, and this is a good way to teach people conflict resolution. So generally, the way they usually run is there's an informal complaint process, and then if that's not satisfactory, there's a formal complaint process. So if someone has gone through those sort of processes and still feels that there's resolution that needs to be taken care of and are unsatisfied with it, there's the OMH customer service line. That would be the place to call, I would say, after you've tried to resolve it with the facility or the program. Geriatrics. People asked about geriatrics, and actually I've asked one of the people here to do a webinar for us on geriatric mental health. So here's the geriatric homepage at the Office of Mental Health. And next one. So some more of your interests that you were looking for. Children's services and medication was a big one. So I want to show folks some stuff here. So this is under our clinical advisories, which is on our webpage. This was a letter from, I believe, Stuart gave it. So he was our chief psychiatric child psychiatrist here, and now our new one is Matt Perkins now. So this is around antidepressants in children and adolescents. It's for the parents to understand what that means and what to look for if they choose to have their child taking that, or if they feel their children need that. Another clinical advisory around children is cardiovascular monitoring for children receiving attention deficit hyperactivity disorder. A lot of those medications are stimulants, so you want to make sure there's no heart problems. And this one did come from Lloyd, I believe. So he's our chief medical officer. Sometimes the titles change. So. Another thing, and this is in psyches, so this came from psyches. This is fast facts, other things about research and child and mental health medications. It's just very important if this is something that, because most of the time this is something that gets discussed with a pediatrician or a family doctor. It is important that if you are deciding to do this, that you make sure you get all the information you can before you do this, because we all want to make the best decisions we can for our children. I have a child, and we would always want to make sure that we do that. Now here's another good thing, and that's not very well known. This has to do with telemedicine. And before I get into that, so right over here it says Project Teach. And Project Teach is about teaching pediatricians and family doctors about how to look for psychiatric issues, and it's basically teaching them what to look for and how to be helpful and how they can be most helpful. The NICAT thing here is telepsychiatry, as you can see. This is for, because there's a dearth of child psychiatrists in general and in New York State and in rural areas especially so. You can access proficient services. You can access experts in the areas and in the field here through telepsychiatry and telemedicine. And again, this is not something that I think is well promoted. So I want to make sure that people are aware of this and that this is available to them, and that this is the web page for them. One of the other things that I think is pretty cool that most people don't know about as far as rural services goes is USDA. You wouldn't think of USDA as something that might be helpful with mental health, but there's actually a rural federal funding database on the USDA website, and they have a lot of grants and low-cost loans for people living in the rural areas. So, and rural mental health can be challenging. So, as you can see, I just typed in mental health, and there's several loans and grants and things here. Geriatric training for physicians. So there's a whole bunch of stuff here. Criminal justice. It's very nice. Indian Health Services, or Native American, they call them Indian. So, all right, and we've got the Bureau of Cultural Competence. Some folks had some questions about institutional racism and whatnot. So we have our Bureau of Cultural Competence that helps to teach people about how to maintain an asking stance and how to respect people's cultures, from spirituality. And even rural can even be a culture in and of itself, coming from a rural area and growing up in one as a youngster. I can attest to that. So peer specialists, the career ladder training and certification. There will be a certification for peer specialists at some point, and that'll come through the Academy of Peer Services that I talked about earlier. A career ladder as far as in state government for peer specialists. We do have some things that we are developing around different levels of peer specialists 1, 2, and 3, but we don't have the 2 and 3 positions approved. So, but in the meantime, what peer specialists can do is attend webinars like this, attend conferences with NIAPRS and NAHAP, join the Academy of Peer Services and learn the different, take some of the different things there, go to CPI, just keep increasing your knowledge base so when the time is ready, you can make that application and you'll be armed with lots of information and you'll be an expert, and that can only help you. Acronyms, so if you go to the OMH webpage, and I'm not going to go through every acronym, but there's a whole list of different mental health acronyms here. So you can see how many there are. There's a whole bunch of them. So sorry if I made you dizzy there. So you can go there and you can take a look. In some ways, it's almost too much in some ways. So what I did is I broke it down and used some of the more common ones. So I'm going to send this to folks. I'm not going to go over this right now because I want to get to some questions, but I'll send this, I'll email this to folks, and just so you kind of know. But one thing I would suggest is when folks are, if you're at a meeting, you do kind of got to play it by ear. You don't want to ask every time somebody says an acronym that you don't understand. Sometimes you just got to wait until afterwards and write down the things that you don't understand and ask one of the people there. Say, hey, can I set up a time with you to meet? Because I want to understand what some of these different things mean. That's how we increase our level of expertise. That's how we become experts. And 9 times out of 10, I've never had anybody say no whenever I've had to ask them if they wouldn't mind sitting down with me afterwards and just going over a couple of the concepts or some of the acronyms that I didn't understand. Because obviously we can't go over everything here in this webinar, but that would be one of the strategies I would suggest that people use. And I think we're getting close. Okay, housing. Housing is always a big issue, so these are some of the different, I wouldn't say shelters, hospitals, jails, and prisons are any place for people to live, but they are places where people are housed. Family care is something that not a lot of folks know about. Family care is usually it's for when people need a level of care and I think it's considered congregate care, but person lives with a family after they get out of usually a state hospital, and they live with the family while they're still continuing to learn how to live in the community. It's really kind of a neat little concept. Community residences are congregate care. Several people live in a building together. Apartment treatment, as people live in an apartment. Again, that's a licensed program, as is family care and community residences. Supported and supportive housing are not licensed programs. Those are more permanent based, and they're in the community, much more integrated in the community. You've got HUD and Section 8, which are also housing programs, very difficult to get into though. Home of Your Own, I couldn't find anything on Home of Your Own on the OMH website, but it is a program that is done through Sony May, SONYMA, to help people with mental health issues, and also, OPWDD as well, to work to give them an opportunity to buy a home. So depending on the different criteria, you could get your closing costs taken care of. It's a 4%, I think 4% or 3.5% fixed loan interest rate. Some of that can get paid for also through the Sony May thing. So it's kind of a neat little thing, but you do have to go through some training. You do have to go through some different training sessions and whatnot. Okay, last thing, just want to point this out, as I said before, this is going to be the April webinar, and I'll just leave that up there for right now. And I think I've gone through all of my slides. No, I'm sorry, there's one thing here on housing that I did want to let people know about. This is the Residential Program Indicators Report. So this is where you can kind of take a look at the different housing programs in your area. So if I were to pull up, I'll pull up my county. So again, I'm not trying to, I just want people to understand that this is out here, and I'm not trying to embarrass anybody or anything like that, or have any particular bias. So this is Rensselaer County. So you can look at your county and you can see that the different things here, you got number of beds, length of stay. What we really want to do is we want to keep that length of stay below 2 years. We don't want people going into these housing programs and spending the rest of their lives there. We really want to help people get out of the system and get out of life. That is sort of like that would be the slogan that I would base all of my other things upon. So we really want to help people get out of the system and get a life. So you can see the different indicators there, and people discharged, people admitted, etc. So not a lot of people know that's up there, but there's a whole host of information that's available on the OMH website, and I only touched on some of it. And again, I touched on mostly the top stuff, and for people who are interested in particular categories, hopefully I've pointed you in the right direction where you can do a lot more follow-up, and we will be doing webinars based on geriatrics and children sometime later in the year. So why don't we do some questions, and I'm sorry I ran so long.
Okay, Tony, the first one is, who would be responsible for contacting a prescriber due to med management concerns that are reported to psyches? If you're not a prescriber yourself and question meds being prescribed, especially during concerning psychotropics that are being added onto one right after the next with children, you get an attitude of, who are you to question?
Well, that is a common issue. So what I would say is that we want to promote shared decision making, which is another big concept that we have. So it's, SDMs, shared decision making. What that says is, especially around medications, is that there's two experts in the room. I'm an expert with me, or in the case of my child. So I'm an expert with me and what works and doesn't work for me and what my values and preferences are. And you're an expert in the field of medications and what they do to people and whether they can be helpful or not. And the two of us need to come together, and we need to make a decision together about what's going to be helpful that isn't going to interfere with the things that are important to me. So employment is very important to me. If I was taking a medication that made me so sleepy that I couldn't get in here in the morning, or when I got here I was just in a zombie-like state or couldn't focus or something like that, I wouldn't take that medication. That's where the non-compliance, so to speak, comes in is when what we call personal medicine, which are the things that are important to you that help keep you well, whether it's drumming or playing a musical instrument or playing in a band or writing or journaling or scrapbooking or whatever it is that you like to do as a parent or as I said, as a worker or whatever it is, other parts of your identity beyond the role of a mental patient, those things are important. And the medication, if it doesn't support those things and interferes with them, is going to be a problem. So where do you go? As I said before, the main place to go would be the doctor themselves, and to talk to them in those terms around what the medication should be doing to help and why it's interfering with the things that you want to do with your life. There was another part to that I wanted to add, but it has slipped from my mind, unfortunately. I hope that's helpful. Certainly, if worse comes to worse, you can go to the Office of the Professions and file a complaint there. You can find another psychiatrist. I know in rural areas that can be difficult. If it is for a child, then you can actually you may be able to call the Justice Center as well when that thing opens up too. So,
and you may be able to utilize the advocacy help in one of these programs that Tony had mentioned today too.
Yeah, that was the piece. Thanks for reminding me. So you are entitled to have an advocate with you when you go to an appointment, either with a clinician or with a doctor. That is a right that you have. So if you want to get an advocate and bring an advocate there to help foster that discussion, you are entitled to do that. So, but try to use it as a partnership. There's a lot of stuff that builds up, and we can carry that stuff with us, and sometimes we carry stuff that happened in the past into our new relationships, and we just have to be careful not to carry that in there. Try to work together, even if we have to be the adults and the professionals in the situation sometimes.
Next question, Tony, is, are programs licensed and or funded by OMH limited to Medicaid and Medicare recipients? Is other insurance ever accepted?
Yes. Yes. I don't know what else to say.
Simple and to the point answer.
Yes.
Okay, we have a question. What or where is the first point of access for OMH programs?
That's a good question. Sometimes it's a complicated question. So sometimes our first episodes bring us into contact with the police. Even not our first episodes, but sometimes we bring ourselves to the attention of the police, and the police bring us in to an emergency room or a CPEP, and there we get evaluated, and we usually get admitted to the hospital. So that's one way, and it's not a very helpful way. Usually, when symptoms first start appearing and people first start having difficulties, the average length of wait before people come in for services is about 8 to 9 years. That's an awful lot of time suffering and dealing with something that maybe could have been dealt with sooner. So, there's a lot of stigma involved with that. So that's another way, that people can come in for services. Sometimes it's through their doctors, sometimes it's through friends. But another point of access, and I'm sorry I didn't think of this, is that usually works with housing, is SPOA or SPOE, which stands for Single Point of Entry or Single Point of Access. And there are SPOA or SPOE committees in each county, and there should be a peer on there. And a person should be able to, we would encourage people to be able to speak for themselves as far as where they're going to go and what priority they should have as far as housing goes. So that committee makes some decisions around housing.
Okay, next question. There seems to be a number of evidence-based practices and the concept of a need to get to the core of the problem. Taking this into consideration and realizing that there is a lack of professionally trained minorities to work with minorities, has there ever been any consideration of state and or federal programs to go to minority leaders and communities to try to bridge the treatment gap?
I don't know, not that I'm aware of. I know that there is a lot of trends or tendencies or the demographics of the professions are, have been stayed the same. Doctors are generally men, nurses are generally women. People of color usually work in the front lines, and Caucasians are usually working in the other fields. So it is still somewhat segmented there,
And there is a caveat here in that some minority populations, such as Native Americans, we can be very limited to how we interact with them, because it needs to be at their invitation. We can't even reach out and say, hey, we have this program, unless we are invited into their communities.
And to follow up with that question, well, another important concept is being person-centered. And if someone is person-centered and people are doing the job well, and they're really following and geared towards person-centeredness, it really wouldn't matter. The stuff that the person was talking about really wouldn't matter that much, because you're really focusing on the person and that culture and everything that that person is about. So whether or not you're of the same, and most of the times we're not, of the same religion or the same background or whatever, it really wouldn't matter, because the clinician would be focused in a non-judgmental way totally on the person and what their particular specific needs are, and it would be so individualized that those other things would happen. But again, that's sort of a little pie in the sky, and it's not the reality on the ground, but that's ideally the way it should work. We'll do one more question.
Okay. Actually, this is one that I can answer very easily. Please send a list of commonly used acronyms.
Yes.
This list is, as with the rest of the webinar, is being recorded and will be available through the archives. And this list can also be emailed to anybody who is interested in asking for it. Simply contact Tony.
Well, I'm going to send a copy of the. I already sent out a copy of the presentation earlier today. I'll send out another copy as well as this particular list of acronyms. That it's a truncated list, but I'll send that out as well. Let's do one more.
Okay, and we only have one more, so that works out.
Okay, good.
What were the questions pertaining to institutional racism you had mentioned?
That was the question. The question had to do with institutional. What about institutional racism? I don't remember specifically what it was, but that was the question that was asked. So I tried to address it as best I could with talking about the cultural competence, and then following up with what we just talked about a minute ago.
Okay. And that is it for questions.
Okay. Well, we finished pretty much right on time. That's cool. Well, it's been a pleasure being here today. I'm very grateful I got to do another one of these webinars. I don't think I've done one since the beginning, since we started these things like 4 or 5 years ago. So this has been fun. I want to thank Tom for joining me today and helping out with that. I hope it was helpful for folks. You will be getting some follow-up emails, and if you do need a certificate, please indicate so. There'll be like a little survey that opens up at the end of the webinar. Just please let me know if there were several people in the room that were with you. Just please include their names as well. I'm going to be honest with you, there will be a delay in me getting them out to you, because right now we are swamped with some other mandates that we have to take care of first. So I do apologize about that, but I do have it on record. If you do it that way, if you send me an email, that's a little harder for me to keep track of, so it'd be best to try and do it through the survey at the end of the thing here. So thank you all for coming. I really appreciate you listening. I hope this was helpful for you, and I'm looking forward to your feedback and tailoring another one like this if we left some things out, because it is a huge system. So thank you very much, everyone. Thank you again, Tom. Bye-bye now.
Thank you, Tony. Have a good day.